and this will be archived. Excuse me. We will post this along with our other recorded webinars on YouTube, and you'll also receive a link automatically in a follow-up email that has that, so you can take a look at this one as well as any others that you may be interested in. Right now we have 64 people online. We'll probably be getting some more folks coming in as time goes on. And during the webinar you may experience some momentary lapses in the audio, especially if you're on the computer speakers. This is normal. It shouldn't interfere with the overall content of the presentation, but if you are having difficulty hearing over the computer, you may want to call into the teleconference. The number is in the welcome message on the control panel, and I can send it out again through the chat function. When the webinar ends, you'll receive a short survey. If you could please just take the time to fill that out. We'll provide certificates for today's webinar if you need credit towards any kind of certification, such as a CPRP or CASAC, or if you need proof of attendance for your work. So today's presenter is Ann Smith. She's from the Family Institute. She's their executive director. She's been with the Family Institute since the beginning of its development in 2002. Ann was initially the senior program coordinator, where she coordinated the implementation of the Multifamily Psychoeducation Group Initiative. In 2006, she was promoted to the executive director and spearheaded the development of the Spectrum of Family Services Initiative. Presently, Ann trains mental health professionals across New York State on how to implement evidence-based practices in family psychoeducation, more specifically, the consumer-centered family consultation model. She also facilitates a variety of training and informational seminars. Ann received her master's degree in social work from the University of Buffalo, where her concentration was in mental health, substance abuse, and family work. She has also completed the Elements of Healthcare Leadership Certificate program from Rochester Institute of Technology in 2009. Ann also has experience serving children and adults with limited capacities and mental illnesses, as well as assisting their families. So it's my great pleasure to have her here today. Family issues and engaging families in the process of recovery with their loved ones is very important, and I don't think we give it enough attention. And hopefully today you'll learn some, and maybe you'll be able to receive further training through the Institute. And with that, I turn it over to Ann. Thank you, Ann.
Thank you, Tony. Good afternoon, everyone, and thank you for joining us today. I'm very excited to tell you about what we're doing here at the Family Institute and everything that's going on. So let's get started. Today what I'd like to do is say hello, which I've already done, and welcome all of you. We will also be talking about the Family Institute, who we are, what we do, and I'm going to talk about our history and what our mission statement is. Then I want to talk to you a little bit about what we feel here at the Family Institute. You know, what does an agency or program need to have to work with a consumer support system? And with that support system is a recovery-oriented system. I want to talk a little bit about that. I'm going to talk about the spectrum of family services options, which is a menu of services that we think programs should offer to families and consumers. I want to talk about a gateway into those family services, and our specific model is the consumer-centered family consultation model. And I'm going to get into a lot of detail about that. And then I'm going to talk to you a little bit about what the Family Institute is doing presently to continue with our mission. I'm going to talk to you about our learning community, which is a new program that we're just getting up and running. And then I'm going to have, as Tony said, I'm going to have some questions and answers at the end. So let's get busy. So the Family Institute for Education, Practice, and Research is a partnership between the New York State Office of Mental Health and the University of Rochester, located here in Rochester, New York, in collaboration with the Conference of Local Mental Hygiene Directors and the National Alliance on Mental Illness. So the Family Institute for Education, Practice, and Research has been funded by the New York State Office of Mental Health for over 10 years. Actually, we're almost finishing our 11th year now. We provide training and implementation support for agencies that are adopting evidence-based family-involving approaches for people with severe mental illness. And to date, we've had many different initiatives. We originally started in 2002, and our first initiative was called the Family Psychoeducation Initiative. More specifically, it was the McFarland model, which was multi-family groups. At that time, we worked with about 34 programs across New York State, and we taught them how to do multi-family groups in their program. When we completed that, we went back to the drawing board and said, you know, we need to make some changes, or what would we like to see programs offer? And we realized one size shoe does not fit all, and we came up with a spectrum of family services. So what we did then in 2006, we worked with about 50 programs to teach them different family services available. At that time, we also created the consumer-centered family consultation model, which we felt was the gateway into the other options, the other menu of services that we could offer people. So we started with the spectrum in 2006, and then in 2008, we actually went around and we trained ACT teams and assisted the VA system on how to offer a consumer-centered family consultation model to their clients. And then in 2011, we started working with the PROS teams, the Personalized Recovery-Oriented System. And at that time, we worked with about 36 programs in that initiative, and we trained them how to do the CCFC model, as well as other spectrum choices, other family services they could offer. And then, again, we went back to the drawing board and said, you know, these initiatives are sort of like a closed system. You know, we have a start date and we have an end date. And then during those beginning dates, we have people fill out an application, or programs fill out an application, and then they join the initiative. And then after that, we couldn't have anybody else come into the initiative. So what we decided is we wanted to, you know, do a broader program, and we ended up coming up with a learning community format. And the learning community format, there's a beginning date when we started a couple months ago, but anybody can join the learning community at any time, and there's not an ending date. So we like the idea of anybody that wants to work with families, with their consumers and their support system and their families, can join the learning community at any time. And I'm going to get into more details about the actual learning community. So far to date, we've worked with over 250 agencies in a variety of settings: clinics, inpatient programs, mental health associations, ACT teams, veterans administrations, which I talked about earlier, PROS teams, and many more different programs. We have trained over 1,200 mental health professionals. We offer training and consultation related to evidence-based practices, as well as organizational changes related to the successful implementation of those practices. So not only do we train different staff at programs, we also help with the implementation piece. And then the one core offering that we created, the consumer-centered family consultation model, is really our baby. We created that off of a model. Edie Mannion out of Philadelphia created the family consultation model. And what we did is we took that model and we enhanced it to make it a consumer-centered family consultation model. So that's what we've done as far as the Family Institute, our program is concerned. But now I'd just like to talk to you a little bit about our mission statement. The Family Institute provides training and technical assistance to licensed mental health agencies in the design, implementation, and evaluation of research-based family interventions for individuals with mental illness and their families. Our work focuses on the important role of the family and the power of knowledge and relationships to foster social, emotional, and mental well-being. We believe that it is crucial that all parties involved in the mental health system understand the relevance and importance of including families and others to assist consumers as they recover from mental illness. So what does the program need to have to work with a consumer support system? Well, we feel that they should be a family-oriented system. They should offer a spectrum of family service options, which I'm going to get into in a little bit. But again, that one-size shoe does not fit all. They should have a menu of services available. A gateway into those family services, and the program that we endorse and like is the Consumer-Centered Family Consultation. And then they need to have a willing and motivated staff. So what might a family-oriented system look like? Well, a family-oriented mental health system ensures that mental health programs routinely and proactively offer, as an option for consumers, a comprehensive education and support services to family members and others in the consumer's social network. The services are designed to engage and involve family members and others in supporting the treatment and recovery of consumers through education, advocacy, support, and problem-solving assistance. So what I'd like you to do is consider the following performance standards that are organized into 3 major areas of mental health programs. So we feel that a family-oriented system would have these 3 pieces in place if they were family-oriented. First, at the assessment stage. Right from the beginning, right at intake, and ongoing assessments are designed to identify the expressed wants, expectations of consumers related to the involvement of family members. So what does the consumer want as far as a support system? The needs, the wants of the consumer's family and support network for information, support, advocacy, and problem-solving assistance related to the consumer's mental health concerns. So not only what does the consumer want, but what do their families and support system also want and need. And then next, the family social network resources and strengths related to promoting the consumer's goals in recovery. So right at the very beginning, assess during the assessment, during the intake, you want to ask them, how are we going to be working with your support system? And make us accountable to be able to do that. So together you have a conversation to discuss a support system. Everybody's entitled to a support system. And then throughout the service planning and delivery. So the program has an accessible system to engage and involve family members for consumers who want and can benefit from their involvement. So the program should have a designated family service coordinator, a person that is going to make sure that they have the family services in place, that they continue to look at their family services, are they serving the needs, and then to alter them or change them or enhance them. Performance expectations of practitioners. So again, practitioners should be expected to routinely offer family services, and particular family consultation services could help decide what programs are needed. And then informational materials. You always have information available to the consumer and their families. And then at the evaluation of outcomes and performance. So you want to have progress notes and periodic treatment plans that identify and address outcomes related to the provision of family programs. You want to evaluate, what exactly you're offering. Strategies to identify and involve family support in the consumer's treatment. So again, strategize as a group, brainstorm as a program, how can we involve families in support? And then we always encourage that the agency or program collects, analyzes, and acts upon the family service data to make continual and informed improvements. So you want to know right throughout their stay. And at the end, I always encourage programs to evaluate at the end. Do an exit interview with the consumers and their families and say, did we serve your needs? Did we reach your needs as far as helping you to work with your loved one? Okay. Now what I'd like to do is just talk about the Spectrum of Family Services menu that I talked about a little bit earlier, about what a Spectrum of Family Services menu can look like. And again, this is just the one that we've created here at the Family Institute. There's many more services that programs could have. These are just a few of the ones that we have designed. And again, it's under the premise that no one size shoe fits all. So we designed by the Family Institute to integrate families of people with mental illness into the intake and treatment planning process. So our menu looks like this. And as I stated earlier, we feel that it's very important that you integrate families right into the intake and the treatment plan. And we feel that the consumer-centered family consultation model is that gateway into the program. And some programs that we have on our spectrum are, these are the general programs that programs could offer, or services, I keep saying program, but it really is services, that they could offer in a program. Family information nights. Family information nights are pretty much like an open house for clinicians, consumers, and their families. It's an evening where you provide information about the agency or programs within the agency or specific services available to families and specific information on community resources. It's an opportunity for an agency to show what it is proud of, and an opportunity for the clinicians and consumers and families to share resources and supports with one another in a non-threatening environment. It can be as simple or as elaborate as the program chooses to make it. The next one is the family education curriculum. Now, the education curriculum is really based on teaching families information about major mental illnesses, as well as coping skills for dealing with the everyday problems and concerns of having a relative or a friend with mental illness. The curriculum is designed to be taught by mental health professionals to relatives and friends of people who have severe mental illness. Non-confidential library or resource library is really just a library that's generally located within the agency. It provides a full range of topic-related resources for consumers and their families. A resource library is a collection of family-oriented mental health materials such as books and articles and brochures and videos. And you can either loan them or give them away. But we always encourage programs to make sure that the materials they have are available to everybody and they're updated on a regular basis. And then family support group is just that. It's a support group for families that, where families can get together and be supported through this time in their lives. It's a place where people can share medical information, get confirmation their feelings are normal, and educate others or just let off steam. The single and multi-family group is a family psychoeducation group, offers a powerful means of improving coping skills, reducing stress, and providing guidance that enhances caregivers. They last usually from about 9 months to about 2 years. It's a very structured program. And then behavioral family therapy focuses on the basic knowledge of mental illness. Their families learn communication skills, problem-solving skills, and goal achievement. They usually last about 60 minutes, and usually it's a weekly time. You meet together for about 60 minutes, and it usually lasts about 3 months, and then it tapers off. But you can go 9 months to a year with behavioral family therapy. And then we always suggest that programs offer programs outside of their agency. And as I stated earlier, we collaborate with NAMI, and NAMI has so many wonderful programs that they can offer. On our menu, we mentioned the family-to-family education, the family support group, family helpline, informal mentoring program, and in your own voice. Those are just a few of the programs that NAMI has to offer. But those are on our spectrum of family services menu. So as I stated earlier, the Consumer-Centered Family Consultation is our program that we created to help programs get them into the door with the consumers and to get them into other choices of different programs. So what I'd like to do now is I'm just going to talk to you about the Consumer-Centered Family Consultation and some of it, all it entails. So the Consumer-Centered Family Consultation model is a brief, education-based engagement and consultation service that is typically completed in 1 to 3 sessions. You can go to a couple more sessions if needed. However, we feel that you're getting into something else if you're doing more than 3 or 4 sessions. But typically it's 1 to 3. It promotes collaboration among adult consumers of mental health services, members of their family or social network, and services provided to support each consumer's recovery. Now ours, it says adult consumers because we at the Family Institute work with adults, but it can be adapted to other programs such as adolescent programs or other services, alcoholism, different programs. It is adaptable. And if you work in a different program and you're interested in adapting this, please don't hesitate to contact me. We can brainstorm together to come up with different ways that you can adapt this program. And at the end, I'll give you my information. The focus of the Consumer-Centered Family Consultation is on the person or the consumer with a behavioral health issue. The focus is not on the family, or is it family therapy, nor is it family therapy. And we really want to stress this, that the consumer is the client. If you remember, I said we train programs to work with the consumers. And so this is a consumer-centered family consultation. That doesn't mean we don't believe in the family or we don't believe in family therapy or family work. This particular model is just a model for the consumer. There's a specific shared decision-making tool embedded in the process of engaging people in their natural support. The CCFC model provides an opportunity to help prevent avoidable hospitalizations and to help facilitate linkage with outpatient services by involving people's natural support in a meaningful way. Consumer-centered family consultation is really similar to other types of consultation. Information and goals of consultation are solicited from the customer. Education is provided. Information and choices are given. And then follow-through is up to the customer. So an example of another consultation would be, for example, my husband and I recently had a landscaping consultation done. We were looking at our yard. We didn't know what we wanted to do with it. I was getting all extravagant and thought maybe we could do a pond, even though we don't have that big of a yard. But so what we did was we called a landscaping company, and they actually sent us a consultant. He came and he talked to us. So we solicited this man to come and talk to us about our yard. He then told us, he walked around our yard and he told us what kind of soil we had and, what kind of grass we had. And he told us some options that he thought would be available to us in the yard. And I talked to him about the actual pond, and the koi pond is what I was looking for. He didn't have a whole lot of experience on a koi pond, but he offered us some names of people that did. So he gave us some information and he gave us some choices. And then it was up to us, and he even, offered that he could do some of the work, or he gave us a different landscaping company that was right in our area. But he just gave us the education and the information, and then it was our choice. It was up to us for the follow-through. Well, that's exactly what a consumer-centered family consultation is. The therapist informs the consumer that this program is available. and then it's up to the consumer on whether they want to have a consultation. And then once the consultation is done, if the education is provided, the information is provided, and once that is completed, it's up to the consumer and their family what to do with that information. So it's really just very similar to other consultations. So at the beginning of the CCSB process, there's the engagement and the planning. So you have a conversation with the consumer, and then if the consumer says yes, they're interested in doing a consultation, then you have pre-planning meetings. And you can have as many conversations as with the engagement piece and as many conversations with the pre-planning. It's all at the decision of the consumer. And then once you decide the consultation will take place, then you have a conversation with the consumer on how you're going to do that, and then you outreach to the family, again, or the support system. And when we say family, we mean that loosely. Any support system, whoever the consumer says is their support, they want to have them support them in their recovery. But you have an outreach conversation with the support system. So family supports involvement, to be or not to be. It all starts with a conversation with the consumer. We have an actual decision guide here at the Family Institute that we sit down and talk to the consumers, and we train programs to use this decision guide. And this guide helps adults with mental health concerns and their clinicians. It's a tool for making decisions about whether or how to involve family members or friends in the support of recovery goals and treatment. I'm just going to talk a little bit about the decision guide itself. The guide integrates the principle of shared decision-making. Together, the practitioner and the consumer sit down and discuss whether they want to have a consultation. The guide provides the consumer and clinician with an easy-to-understand, practical, step-by-step approach to the decision-making process. The guide offers a framework to begin a conversation with the consumers about including others in their recovery process. The transparency of a written guide helps to build safety and trust in the therapeutic relationship. And I'm just going to briefly talk to you, give you the steps. It's actually a six-step process. Step one is just thinking about involving people. And again, you can sit down with the clients and talk as long as the client wants to talk about this. Not just sit down, talk about it, and it's done. You can go over a very long period of time to discuss whether they want to have somebody in their life involved in their treatment. So you want to talk about thinking about involving people, just their choice. Involving others is their choice. They decide what kind of help, if any, they want. And then you can go through a list of different people that they might consider. The thing that I want to stress here is the consumer is in the driver's seat at all times. So you're sitting down with the consumers, practitioners are sitting down with the consumers, and they're having a discussion about this. But the consumer is the driver, and the practitioner is in the passenger seat. Somebody described that in one of our learning communities a couple weeks ago, and I love that. The consumer is doing all the driving, but the practitioner is in the passenger seat helping them to say maybe you want to go this way or maybe you want to go this way. But ultimately, it's the consumer that makes the decision. And then you want to talk to the practitioners. We encourage them to sit down and talk to them about concerns that they may have about involving somebody in their program. And then we have a list of different ideas or concerns that they may have. And then in step 3, you want to talk about possible support people. Again, who do you spend holidays or birthdays with? Who do you turn to for support? Who praises or encourages them? It doesn't have to be a family member. It could be a minister. It could be a sponsor. It could be a compeer. anybody that they feel may help support them in their recovery goals. And then you want to talk to them actually about what takes place in a CCFC, exactly what it is. And then you want to talk about pros and cons of family support involvement. What's the positive things about involving somebody in your treatment plan? And what's the negative? Because there are going to be some on both ends. And then the next step. So then you want to talk about what is your decision. Ultimately, it's up to the consumer. They may say, no, not interested. You may ask, can we revisit this a few months down the road? Can we revisit it? They may say, well, I am interested, but I'm not sure who. So again, you just want to have a discussion. And if you're interested in seeing the actual decision guide, please go to our website at www.nysfamilyinstitute.org. So the consumer says, yes, we're interested, I am interested in having a consultation. Well, then you want to sit down with the client and you want to talk about a pre-planning. You want to sit down with them and have a pre-planning meeting or meetings, it depends. After the consumer chooses to participate in a CCFC to help support their recovery-oriented goals, and in order to increase the likelihood for a successful CCFC, it's highly recommended to conduct a pre-planning meeting or meetings. Again, it's up to the consumer how many you need to have with the consumer and the clinician prior to the actual CCFC occurring. So prior to the CCFC occurring, you're going to sit down and you're going to talk about and plan out the CCFC. So you're going to have 1 to 2 or 3 or 4 conversations between the consumer and the practitioner. The emphasis is going to be, again, the consumer is in the driver's seat and has the choices. You want to plan. What's the goal or the issues that you're going to discuss during the CCFC? And just as importantly, what are you not going to discuss? It's very important that the practitioners sit down with the consumers and say, okay, what do you want to talk about and what don't you want to talk about? And then honors that. You want to plan how you're going to outreach to the family. How are you going to, together, the consumer and the clinician, how are you going to make a plan on how you're going to reach out to the families? Then you want to prepare the consumer that families often want to share some perspectives and experience about what they have gone through during the times that the person has been suffering through this mental illness. Because you've got to remember, the consumers or the families are going through it with them, whether they're in the room or not. They have lived through this. So you want to talk to the client about that. You want to say, they have a right to voice their concern. Let's talk about that. Is that going to make you uncomfortable? How do you want to handle that? Again, the client decides. They may say, I'm okay with them talking about it with me present. And they may say, I don't know if I can be comfortable. You want to make a plan. All right. If you're not going to be comfortable, what do you want to do? Do you want to step out of the room? Do you want us to have a separate consultation? Again, the consumer is in the driver's seat. And then you want to talk about how to handle curveballs. And what we mean by that is the what if. It's a time during the consultation, it can be a very vulnerable time for everybody. It's a new program. They haven't, a lot of people have not been all in the same room to talk about this. So they may end up, you want to talk about the what if. Again, it's just making a plan so everybody is comfortable. It can be a very anxious time for everybody. The clinicians, the families, as well as the practitioners. It's a new program, and people can be anxious about it. So this is a very good way to set it up so that at least the consumer and the practitioner can have a plan on hopefully what's going to occur. Sorry about the changing of the slides. I keep losing my mouse here. So if you'd like to take a closer look at our pre-planning tool, again, go to our website, www.nysfamilyinstitute.org. what now? Now that you've engaged with the consumer and you've done your pre-planning meeting, now it's time to engage with the family or the support system. And what we have is we actually have a brochure that we give to the consumer, and if the consumer would like us to, we mail them out to the families. We always recommend to programs to have them in their waiting rooms or to pass them out during family information nights or family education nights, just have them around their area. But the brochure actually talks about what a CCFC is, what's the purpose of a CCFC, how can family members and other supports contribute to a CCFC, who participates in a CCFC, and how somebody can find out about attending the CCFC. So now you've outreached to the support system, and they've all agreed that they want to have a consultation. So you actually, the face-to-face consultations begin. So during the face-to-face consultations, you connect with everyone, and I'm going to get into a little bit more detail. You refine the wants and needs. You plan and problem solve. And then you talk about the next steps, just like I did when we did the landscaping consultation. The man came in, he connected with my husband and I, he asked us what our wants and needs were, we planned out, he gave us some information, we planned and problem solved, and then the next steps. And then this consultation ends. Just because you have one consultation doesn't mean you can't have more. The consultation itself may end up being 2 or 3 or 4 sessions. You may have just one consultation that can cover all the areas that you need, or sometimes a client will say, I only want you to cover this specific area, and it only takes one time. Some other times you may have 3 or 4 or 5 things they want to discuss, so you may have more than one consultation. You may also have just one consultation on one specific subject, and then 2 months down the road need to do another consultation, or a month down the road do another consultation on another subject. So there's many ways to the different consultations. For example, in the landscaping consultation I talked about, you know, we may have just met with the man about the lawn itself, and then if we didn't end up doing a pond, but if we did end up doing a pond, I may have had another consultation on how to do a koi pond. So that's the same premise again. So this is exactly what a consultation looks like. You start by connecting. And what we mean by connecting is in a couple of different things. One is we always suggest that the practitioners talk outside of the mental illness. Just talk to the people as people. You're going to get down to business no matter what. So just say, how are you today, the weather. You may notice something within the house or out in the yard or something that you, for example, a motorcycle. I personally drive motorcycles. If I saw a motorcycle in someone's driveway, I would ask them what kind it is and get into detail. So you just want to talk outside the mental illness. Like I said, you're going to get down to business, but just connect with the family or the support system as people. Then you're going to, as you're connecting, you're going to be receiving information. You're going to be supporting them. You're going to be offering hope, and you're going to be empathizing with them. You're going to just have a conversation about the mental illness and how it's affected their lives. Then you're going to move on to defining and prioritizing the wants and needs. Again, you're going to be working on the understanding of, do you know why we're here today, what we're going to be talking about? You're going to be acknowledging, this is what we're going to be talking about. You may have some other needs, but right now this is what we're going to be talking about. One of the things that we always encourage, and when I do consultations, when my colleagues do consultations, we always bring NAMI brochures, and we always bring family guidelines. And the family guidelines are just a list of some basic facts and information about what family members may consider their efforts to help their loved one. It's like a 14-step guidelines to help families. And we always bring NAMI, and I always encourage practitioners to tell the consumers before they do the consultation, I will be bringing a NAMI brochure to help with your family. I know that's not what you want us to talk about, but families have a right to have support. So I always bring a NAMI brochure and then the guidelines, and I go through the guidelines with the consumer before so they know what they are. So you're going to define and prioritize the wants and needs, and then you're going to manage the agenda. Now, if you've done your pre-planning meetings and you've talked to the family on the phone, you're going to pretty much know what the agenda is because you're going to have worked with your practitioners are going to work with their clients to say, okay, this is what we're going to talk about. Sometimes clients will just say, you know what, talk about whatever you want. So then you can call the family and say, well, we want to do a consultation, and your loved one has agreed to talk about anything that you need to talk about. Again, the consumer's in the driver's seat. Then you want to plan and provide the next steps. You want to give them the education, the support, the practical guidance, problem solving, whatever was decided what is going to take place in the consultation. And again, the referring to NAMI. Always, always, always recommend that. And that is the consultation in a nutshell. Again, I said it could be 1, 2, 3 sessions and different ones. As I stated earlier, we've been doing trainings across the state for some time now. These are some preliminary evidence that we have heard from practitioners. We've heard from 51 clinicians describing what their improvements in the following. So what they have found is that clinicians felt that connecting with their families after they've actually done a CCFC, they felt that the families understood the mental illness and substance abuse much better. Their involvement in the supporting of the treatment and recovery was better. The families wanted to be involved more, or felt that that the programs felt that the families should be involved more. They felt more at ease with it. The perception that they are better supported. Families felt better supported after receiving a CCFC. And then the communication and comfort with the treatment staff. Families felt more comfortable with the treatment staff. And then with the consumers felt that the communication with their families, quality and quantity, was much better. And that their comfort with and value of the family involvement. They felt that family involvement was more important than they had in the past, or they saw the value of it. And then their perceptions of support and understanding by others. They felt more supported and understood. So these are just a few of the really great things that we saw after clinicians actually did a consumer-centered family consultation. And this is just some of the stuff that we've heard. So that's it as far as the consumer-centered family consultation model is concerned. And again, as I stated earlier, we work with practitioners that work with adults, but this program is very, very adaptable. I stated earlier that we actually work with the VA system to help them work with the consumer-centered family consultation model with people that were just coming out of the war. Very adaptable. So what is the Family Institute doing presently to continue with our mission, to continue to help licensed mental health programs across the state become more family-oriented? Well, as I stated earlier, we were doing initiatives before, and now we have changed to the learning community format. So what does a learning community format look like? Well, the learning community is a network of providers who work in partnership with the Family Institute to plan, implement, and evaluate approaches to involve family members in a way that supports the consumer service plan and recovery. The learning community format is set up in a way that programs will choose from the spectrum of family service treatment options on what their individual needs are in relation to family involvement with their program. So the programs themselves say, well, we could probably offer this program. We might not be able to offer this program. So it's up to the actual program on what their culture is and what they can offer. It's not up to us to tell them. And then the Family Institute facilitates the learning community and provides implementation support to assist providers who are focused on a common improvement efforts such as developing effective family-involving services. So we not only help with the actual family treatment options, but we also help with the implementation of it. We support the program to be able to offer different family programs within their program. And as far as the network of providers, it's across New York State. We break the state up into 5 regions, and each region has a project coordinator that oversees each region. However, the programs that we offer, we get everybody on the line. So this way, the people in Poughkeepsie know what the people in Buffalo are doing, and it's across the state because there's so many different things that people have to offer, and we want to make sure everybody can hear what everybody else is doing. In the initiative, we actually broke the states up, and each separate region only talked to their own region, and we decided in the learning community we wanted to open it up to everybody. So the programs in the learning community identify and support selected staff to participate in a one-day training on the CCFC model. We insist that they have the core staff trained in the CCFC model, and we do that face-to-face. So we actually go across the state and train programs on how to do the consumer-centered family consultation. And we also encourage them to attend a half-day train the trainers training so that they have staff within their program who can teach other staff on the CCFC model. We always feel that if you train one staff person in one program and then that staff person leaves, then so does the program. So we highly encourage the programs to have staff that can actually become trainers, and then they go back and train other staff within their program. Some of the learning community activities that we have scheduled every month are online meetings for program leaders, supervisors, and frontline staff. So we, for example, last month we had a CQI meeting, or actually that's this month, CQI, which is a continuous quality improvement team. And what we do is we talk to them about how they can work with to implement this program in their agency. And then we talk to frontline staff. What's working and what isn't working? Where can we help you to actually get the CCFC model up and running? And if you're having problems with the CCFC model, what can we do to help you? Access to other teams and staff who are experiencing similar and challenges and successes, and that's what I talked about when we break the region up, but everybody can get on the calls across the state or on the webinars. Topic-oriented webinars. Recently, we just had a webinar with an Office of Mental Health representative come on and talk about billing and how important billing is. We've had family guideline webinar. We've recently just opened up the webinars, and we've had 3 so far to date. Access to additional resources through our website. We are always updating our website. At the trainings, we give everybody a memory stick for each program and tell them to go onto our website and download everything that they need, and we continue to update that. And then individualized program-specific consultation is needed. This is where, as I stated earlier, each region has a program coordinator. So if a program is having problems or just need booster sessions or just need help, we encourage them to call the project coordinator, and then they'll have one-on-one sessions, or however, they have a brainstorming session where they can talk about how can we help you with implementing this program or family programs in general. And then regular review of performance indicator data with programs to help focus their efforts on practice improvement. We ask that every program submit data on a monthly basis. And it's just, they do it through our website. There's 6 questions. How many clients are in your program? How many of those clients have been approached about having a consumer-centered family consultation? How many of them have agreed to it? How many families have you outreached to see if they will do the CCFC? And then what took place during the CCFC? Or actually, how many CCFCs actually took place? So this is, and that's performance indicator data we want, for our information, but we also encourage the programs to look at the information to see, okay, what's our problem or what's working, what isn't working. So everybody can learn from that data. It's to help focus the efforts on the practice improvement when it comes to family services. So that's the Family Institute program that we offer and all the things that we do. If you're a program that's interested in learning and joining our learning community, please feel free to contact me, and I'm going to give you that slide in a second. If you're family members and you have a loved one that's in a program and you want your program to offer family services, call me and we can brainstorm on ways that you can approach your program. If you're consumers and you're in a program and you don't have family services available, give me a call. I can help you to work with your program to talk about family services. So I'm going to put up my information, but this part concludes the PowerPoint piece of the presentation, but we're going to open it up to questions now, and I think I'm going to turn it over to Tony with questions. And there's my information.
Excellent. Thanks, Ann. That was very informative, very helpful. We just have a few questions at the moment, so I want to encourage people during this time to send in any other questions that you may have, and then we will get to answering them. So while those folks are doing that, let me ask a couple questions, if you don't mind. What about, do you engage any families whose loved ones are involved in the forensic system, in our forensic hospitals or prisons?
We don't right now, but that doesn't mean it's not doable. And if somebody is interested in the forensic population, call me and I can help brainstorm with ways on how they can approach the forensic system.
Excellent. Thank you.
I'm more than happy to send information out as well.
And would you mind scrolling back to slide 21? And then we'll come back to your information.
Okay.
So I thought that the decision guide was very important, and I thought that we should highlight it. I hear from families that their loved ones, or they're being told by the clinicians or the providers that they're not allowed to speak to them, they're not allowed to give them any information, they're not allowed to confirm or deny that this person even exists. So those are the kinds of phrases that families get really frustrated with. So I really like this, and I just, from the other perspective, I've also heard from clinicians and from consumers that, you ask the question, do you want your family involved? Patient says no, and then that's the end of it, and then no questions asked. And we should respect the patient's preferences and rights, but I do think that maybe a little bit more information could be shared, and that sometimes I feel like, especially when it comes to HIPAA and sharing information and respecting confidentiality, that it's not an all or nothing thing. That sometimes the families are they're concerned about their loved one. They just want to make sure that the person is okay. Not necessarily that they want to get a lot of clinical information, but just they want to know how their loved one's doing and if they're doing okay. And I don't think that gradation and that delineation is stressed enough. So I would really encourage people to just explore it a little bit. Just leave it out there as an option. If somebody doesn't want to do it right now, just leave it out there as an option for them, and maybe they'll change their mind later. But I hate to think that it would just be, do you want to? Yes or no? Or you don't really want your family involved, do you? Okay, So
right.
Those are the kinds of things that I've heard, and I'm hoping that more education through the Family Institute, more information out there will help engage the families, because they can be a very, very valuable resource if they're engaged properly.
Well, it's funny that you should say something, Tony, because we joke when we do the training is you can talk anybody out of anything, or you can
Yep.
you can talk anybody out of anything. We really, really, really encourage the practitioners that we train. We don't want them to say, do you want us to work with your family? We say, how will we be working with your family?
Mm-hmm.
How will we be working with your support system? And that's a whole different process. You know, it's, do you want to work with our family is a yes or no answer. How will we be working with your family? You have the consumer stop and say, oh, wait a minute. How? How am I going to have a support system? And we really encourage the practitioners to talk about support systems in general.
Mm-hmm.
Everybody's entitled to a support system. Everybody should have a support system. I mean, me personally, I have a lot of support systems. And so if you talk about it as support, everybody's entitled to be supported, especially when you're in crisis, especially, you know, when you're going through something, you look for more support. Mm-hmm. So everybody should be entitled to a support system. So what we always encourage the practitioners not say, do you want us to work with them? Because it's checked. Oh, ask them if they wanted it. Checked. Nope, they said no. That's checked off. Now let's move on to the next thing. It's no. How will we be working with your support system? And let's talk about a support system and how important it is. So, you know, in our trainings, we really want the practitioners to just tweak how they ask who's going to be involved in your, you know, how are we going to involve somebody?
Mm-hmm. So I think
that's really embedded in the decision guide.
Yeah, and that's why I wanted to just touch base on that particular slide. So just if you don't mind going back to your contact information so people would be able to contact you, because I think you've already answered this, but the very first question is, how can our agency get the training in CCFC? So it would just be to contact you?
They can contact us. I'm encouraging people, programs to join our learning community. Mm-hmm. Anybody can join if they're a licensed mental health agency program in New York State.
Excellent. The next question is, how important is it to have consumers attend with families during informational and support group sessions?
What was the last part? I'm sorry.
How important is it to have consumers attend with families during informational and support group sessions?
Well, informational and support group, again, it's up to the program. If the program wants information nights, I always like the information nights. It's almost like open houses. You know, if you're a new program and have an open house, invite the consumers and their families and make it just a very enjoyable. I mean, I think of when my son was in school, when they had the open houses, I would go to his school and see his artwork and different programs that he was working on. It was a very, very exciting time for my child to brag about what he was doing at the program or in school, and the teachers to brag about what they're teaching, and then for me to see what was happening. So I think information night, again, it is up to the program itself, but I always feel that why not? This is their loved ones where they spend a lot of their time, so why not have them included? But again, it's up to the program. Education nights, again, it depends on what you're working on, and as far as support groups go, the program could have two different kinds of support groups. They could have a support group with consumers. They could have a support group without consumers. Again, it's up to the program. We don't tell any program how they should run their program. But personally, I think you could offer both.
Now, when you were answering that question, that sparked something for me around families and their surprise and shock sometimes about what their loved ones are capable of. Sometimes they'll say, well, I've heard it many times, like, well, I didn't know they could do this, or I didn't know they could do that, or I didn't know they were, the families, we tend to, we know each other well. We tend to develop habits and patterns and scripts that we, scripts, not prescriptions, but scripts that we follow. My son's script right now, he's 8, and his favorite line is, "I don't know." So we kind of develop these things in our expectations, and we get I think we get a little embedded in that. And then when we see people, our loved ones outside of that role in the family, people get surprised. Parents seem to get surprised at what their loved one is actually capable of doing. and it's always pleasant, but we would hope that, there would be a little more communication and whatnot, so there wouldn't be so many surprises.
Well, Tony, in the same vein is a lot of times practitioners are sort of shocked when they do see their clients with their family and they see them in a different light.
Mm-hmm.
And they're shocked at their clients and they have a different life outside of their program. So, it works all the way around. We've heard that many of times in consultations. I didn't know this about my client. And it's the same thing you're saying, that families didn't know this about their loved ones. So it's really sort of breaking down the barriers, just getting to know everybody as people.
Yes, instead of as roles that they play, as patient or as victim or as family member, or that's exactly what we've always been trying to preach when we talk about person-centeredness and what you talked about today. So the next question is, what have you discovered about the percentage of consumers who agree to a consultation with this model of approach?
Well, our data has shown, and again, I'm not the data person here, but we would hope for more clients saying yes to having consultations. Our numbers have not been as great as we would like them to be. But again, one of the things that in our last initiative, we saw that by collecting data, and what we did is we came up with the pre-planning meeting. Because the data we had collected, hold on one second, Tom Jewell's on my door. He's the data person. Hold on. Mm-hmm. From before the decision guide, it was a fifth. So that was about 2 years ago. And now it's about a third. So that was before the decision guide. Mm-hmm. And since the decision guide, we've added the pre-planning meeting. So we're hoping the numbers will even get better.
Yeah, I think that was an excellent tool. And I did go to the website, and under the resources, I would encourage everyone to go there. I did put the website link in the email that I sent, and it's also in the PowerPoint. So I would really encourage people to go there. Those resources, they've got all of these things right up there that you can download and take a look at. And I found them very helpful. And I think that decision guide is important.
We'll send you everything you need. Go on our website. If it's not there and you need something, call me. We'll get it to you. Very resourceful.
So the next question is, who pays for these sessions? If it's insurance, this uses up 2 to 3 of the allotted sessions.
Yes, it's insurances that pay. Some programs actually just say they know how important it is, because you could technically do a consultation on the phone, but you cannot get paid for it. Mm-hmm. Some programs will do consultations without being paid, but insurance is covered. Medicaid, it's under the, you bill for them. Each program is different as far as how the billing works, and I'm not that familiar with the billing.
So I'm glad you said that, because I have a billing question for you. And I'm not sure what the acronym is here that the person's using, but this is, if insurance is used, is the family member or the consumer the IP?
Okay,
the insured person, maybe? I'm not sure.
We only work with the clients and the consumers, and the consumers is the person that you bill under.
Yeah, that's what it sounded like throughout the whole presentation, was that the consumer is the focal point and the family is, a collaborator or an ancillary component of that. If that's the way I understood what you were saying. So.
Well, you can bill if the consumer agrees to having the consultation and it's on their treatment plan. You can bill if you just meet with the family. But again, I don't want to get into the technicalities of the billing. I don't want to give the wrong information.
But it would be the consumer's insurance that's paying for it, not the family's insurance.
Right, the identified patient.
Right. Identified patient, that's what it is. That's what the IP stands for then. Okay.
So in this case, it's the consumer and the CCFC.
Got it. Next question is, wouldn't a well-trained family treatment-oriented therapist do much of this in the course of treatment?
Well, a family therapist is going to do, if they're there to do family therapy, they're going to do family therapy. Consultation model is separate. And if you remember, I talked about the landscaping consultation. A consultation is not family therapy. If you were doing a consultation and the consumer agreed to it and said, you know what, I want to do family therapy, then the practitioner, if they're a family therapist, they take off the hat and they say, we are now done doing consultation. I will now be your family therapist. Or if they feel that the consumer can benefit from family therapy, they can send them somewhere else to do family therapy. But they're not the same.
Mm-hmm. And certainly this not all of our well-trained family treatment-oriented therapists may not be as available broadly, especially maybe in the rural communities. So these are really helpful tools, and if the learning community is available to help them get up to speed on those types of things.
Right.
So next question is, do you have any measures of effectiveness which could evaluate the relative success of various providers? If not, could you develop some? And would you be willing to help providers to compare their effectiveness and learn from each other how to get better results? So there's 3 questions in there.
Tom Jewell is right in the other office. He's my data collector. He's my research director. So he probably could answer this. Tom, do you want to come over here if you hear me?
Okay, well, while he's doing that, why don't I go on to the next question.
Okay.
So is it appropriate for peers to do CCFC as part of a formal peer support program?
If a peer is trained in the CCFC model, absolutely.
Mm-hmm. Excellent.
We have trained a few peers across the state. They are very, very grateful that we have trained them in the area. But one of the things, the particular program that I'm thinking of, actually, because you can have more than one consultant in the room. So you could have a second consultant in the room. We always encourage to have a professional, a social worker. The main people we train are social workers, but we've trained other people too.
Mm-hmm. And sometimes peers who have had experiences with maybe being apprehensive or may share the same experiences of being apprehensive about engaging, having their family involved. Having them share that is an invaluable resource towards engaging folks who are maybe a little nervous about the unknown or maybe ambivalent about it themselves.
Absolutely, and we encourage that in programs. If you've had a CCFC and it was successful and rewarding, then we encourage the clinicians to talk about it with other clinicians, the clinicians to talk about it with other staff, the consumers talk about it with each other, family members, family information night if you wanted to have families come in and talk about the CCFC model and how successful, or even if it wasn't, certain things come up and, I wanted to do, it should have been done this way or whatever, but we highly encourage people talking about it and its successes and how it works.
Yeah. Next question. So, this is more of a statement, and the word I was looking for was collateral, not collaborative. In individual treatment, there can be family education sessions and collateral sessions. That's what this person is saying.
Oh, okay.
So, next question is, have you ever utilized Mary Ellen Copeland's Wellness Recovery Action Plans?
I haven't personally. I'm going to put it on speaker because Tom's in my office.
Excellent.
So, am I still on?
Yes. So Tom, you want to field these questions? Good to sort of hear you again. I haven't seen you in a long time.
I know. It's good to hear your voice, buddy. And hello, everyone. Sorry to be kind of barging in here a little bit. I did hear the question about some of the evaluation aspects, and just to let people know, our primary focus for the evaluations thus far has been, in one way it's called a feasibility studies. So believe it or not, there's a whole field of research about when you do trainings and prepare materials, will people who come to trainings actually end up implementing the intervention that you're teaching. So that's one focus. And then the good news there is that a lot of people throughout New York State have really implemented this approach, and we call that uptake. So that's one area of focus. The other is more along the lines of impact of CCFC, as the person asked the question about effectiveness. And we have only scratched the surface when it comes to understanding the full impact of CCFC. So, for example, we have done 2 studies to date that have looked at the impact of CCFC through the lens of the perceptions of the practitioner. So we've basically gotten the practitioner's views about the impact of CCFC on clients and family members and things like that. We have done some structured interviews with several sites where we've done interviews and transcribed them with consumers, with family members, and with practitioners. So we have a lot of data that we're right in the midst of analyzing. So, you know, there's a number of things we've done where we have not yet, I know this is a long answer, but where we've not yet been able to specifically drill down is the question of for which types of consumers or for which group of people with which issues and which kind of family constellations and which programs does CCFC have the most impact, and that's we think of that as an area for future study. So if the person asking the question is interested in kind of partnering with us on that or brainstorming, we would be happy to do that. And some of it is resource issues. You know, our funding is such that we do some program evaluation of these activities, but the bulk of the funding that comes into the Family Institute is on service delivery, training, and implementation support that we provide to agencies. So we're always looking also at you know, securing additional resources and grants to help us better research the model itself.
Thank you. You should stay right there. You should stay right there because I have another question here that has to do with evidence. And so is there evidence of impact on clients' improvement in symptoms of the consumer? So in other words, global assessment of functioning scores improving, symptom checklists?
Great question. Our fantasy is to gather that information. We haven't been able to pull it off yet at the very specific client level. All we've been able to do is, again, via surveys and self-report from practitioners as well as interview data with consumers and families. So that really is the next frontier, if you will. One of the things that Anne did not mention, however, just because it wasn't in our slide set for this one, is that we did do some you know, surveys of practitioners with the standard Likert scales, you know, rate from 1 to 5, strongly agree to strongly disagree, a number of items based on some of our earliest studies with CCFC. And in my mind, one of the most interesting and important findings from those surveys that we did 2 years ago was that the practitioners told us that the CCFC and doing this with consumers and just having these conversations with people, it did not just have an impact on kind of the consumer's family relationships or the family understanding and some of the things that Anne went through, which are also important, but it also impacted the treatment alliance. People said, the people I work with are more forthcoming. They seem to trust me more now. They're more open to all areas of treatment in the program. They're attending groups better and seeming to get more out of them, and those types of things. And that they're really invested even in different ways in their treatment plan and kind of following it as long as they've had a say and input in it. And from that we did glean people saying that there were improvements in mental health and people's overall quality of life assessments. So there was some hints of data to support it, but again, nothing as detailed as the GAP scores or symptom checklists or even a randomized study. That type of work just takes resources, quite frankly, that are beyond the scope of what we've been able to do so far.
Well, it certainly makes sense that the clinical alliance would become stronger. I mean, you're not looking at someone in your chair as a collection of symptoms anymore. You're looking at them as, you know, a whole person with a whole history and a family and other interests, you know, so that certainly makes sense to me.
Yeah, that's exactly it, Tony, and that's what we've heard from, again, from people around the state. They say that choosing to implement this approach has just changed the nature of what they do with people. As you said, more holistically, who is this person in front of me? What are their supports that may be with them for a lifetime? Let's talk about connecting them with those supports and you know, getting people the support that they often want and deserve.
Okay, so I have another question here. It's a little challenging. So it says, what good is any program that has no proof of effectiveness for consumers? So I didn't hear exactly that there was no proof of effectiveness. I thought that some of this was based on McFarland's work and that there were some evidence-based background to this.
Oh, sure. No, that's a fine question. That's I think if I was on the other end, I'd be asking that one also. You know, we think of that in two ways. One is, you know, we have some evidence in the form of interview data and practitioner surveys, and that's really the start. And like I said, it really just scratches the surface. But Tony, you're exactly right. Really, this whole model, we didn't just kind of create it from scratch. It is based heavily in the guidelines that were recommended by the PORT study, the patient outcome research team on schizophrenia that's been working for over a decade now, to really outline here are the key ingredients and the evidence-based kind of practice standards that should be implemented. So we've drawn heavily from the family psychoeducation literature, and then we combined that with drawing from a group in Pennsylvania that has worked with a consultation model that also has several studies and research. So actually we've with the CCFC model is an adaptation of the consultation work out of Pennsylvania, and then really infused with the evidence-based principles by you know, Dr. Bill McFarland and others with family psychoeducation. So again, so it's, you know, it's based largely in the principles, but yes, when it comes to hardcore randomized trials of this specifically, that would be the next step for us, but we're not there yet.
Mm-hmm. Well, thanks. I appreciate you taking that question. I don't have any more up on the board right now, so I'll give it another minute or so, and if we don't get any more in, then we'll close out the webinar for today. So there is one thing that I did want to just to mention. I don't think that I would be a good advocate or a good activist if I didn't, but I want people to in the audience to understand that there are a lot of different ways to describe you know, people who receive services, either recipients or clients or consumers. There is a significant number of our folks in the mental health system, especially in New York State, who would say that you know, the referring to this as a mental illness may not be the way that they would particularly frame it. They would probably say something along the lines of, well, having a very traumatic experience, having a very, you know, difficult childhood, or having different things, that it's actually the mind is actually trying to self-right, or we're trying to balance ourselves, and the way that we're doing it is through the symptomatology that is shown, and it may not be effective, but it's more of a reaction, and that the mind is actually healthy, that it's not ill, but it's reacting in a way to something that is a very unusual or very uncommon traumatic experience. So I did want to just, you know, I did want to share that there's lots of different ways to frame it, and that would be one of the ways that some of my counterparts would frame it.
Sure.
So I don't see any more questions coming up. I thank you for listening to me on that particular point, and I want to thank you very much. And Tom, thanks for joining us at the last minute to help with the data questions. Ann, this has been very informative. I think that we got a lot of good information out to folks, and I'm hoping that more people will contact you and take advantage of the resources and the information and the trainings that you're offering.
Well, thank you for having me, Tony, and it was really great being able to put it out there. And I really want to encourage people to call or email me if they have questions or concerns at all. We're only a phone call or an email away.
Cool. Thank you very much. So I'm going to end the webinar now, and just to remind folks, there will be a little survey that pops up, about 4 or 5 questions. If you don't mind, if you can just please take the time to answer those, that would be great. Our next month's webinar will be on May 22nd. That's a Wednesday, same time, 1 to 2:30, and it will be on the role of spirituality in recovery. Another, very important topic that I think is often overlooked. We usually get a very high percentage of people joining us for any topic, any webinars that we do on the topic of spirituality. So that one and work seem to be the 2 big ones that we get a lot of folks on. So I'm looking forward to that one as well. Our speaker for that will be the Deputy Director here at the Office of Consumer Affairs, Joseph Swinford. And with that, I don't see any other questions, so we'll say goodbye to everyone. Again, thank you, Ann. Thank you, Tom. Really appreciate it. And thank you all for coming today.
Thank you.
Thank you,
Bye,
Tony.
everyone.
Bye-bye.